Hey guys, welcome back to Quick Nursing Shorts with Smita. And today the topic of discussion is peptic ulcer, which is very important for 10 marks in your nursing exam. And it could be asked as gastric or duodenal ulcer, or it can directly be asked like peptic ulcer. So do not worry, the content is you can write the same content even for the gastric or duodenal ulcer. And if you're getting peptic ulcer, then just write copy the same, and do not forget to mention what if they're asking for gastric ulcer, then you have to define and say it is called as gastric ulcer. Okay, so like that. Now we'll start with very definition. Definition says a peptic ulcer is an excavation that forms in the mucosal wall of the stomach, or in the pylorus, or in the duodenum, or in the esophagus. So in common language, if I say ulcer is something, um, if it because of the causes could be HCl acid formation, the more secretion of HCl acid, or it could be any infection or bacteria which starts to eat out the skin, the internal skin, which we call as mucosa. So these causes will start eating out our mucosa of the stomach, or maybe of the pylorus region, or maybe of the duodenum, or in the esophagus. So and then gradually that hollow and that eating out part will start forming as ulcer, which is very difficult to be treated later on. So peptic ulcer is frequently referred to as gastric, duodenal, or esophageal ulcer depending on its location. Now we'll move on to the other slide. It says duodenal ulcer and gastric ulcers incidence, malignancy, chances, and risk factors. So here I have divided these two into two, or and at the same time I have put both of these two in a same slide just to show you what are the differences. So you can just rule out what the differences, because there is no much difference, but yeah, there are some critical differences which you have to keep in your mind. Once you get the question, according to that questions only you have to write the answer. Okay, so in duodenal ulcer it says the incidence is being seen that under age 30 to 60, in this age period only the men and women get this duodenal ulcer, and the more chances of duodenal ulcer is in the men. It says the ratio is 3 is to 1, so it is seen that the chances are 3 times more in men than women. And 80% of the peptic ulcers are the duodenal. So it says that duodenal ulcer are the commonest kind of peptic ulcer seen. Now, in gastric ulcer, we can see the incidence. It says that usually 50 or after 50 of age, the person gets gastric ulcer, and here both the male and female can get it. The chances are equal for both, and it is 15%. It's seen like 15% of the peptic ulcers are only gastric, so yeah, it is less. Now malignancy, it says that the chances of turning into a cancer. So in duodenal ulcer, the chances of turning ulcer into cancer is possibly rare, whereas in gastric ulcer, chances of turning these ulcer into the cancer cell is actually more than the gastric duodenal ulcer. Now risk factors and the causes. So the causes says Helicobacter pylori bacteria, which is quite common in any digestive system disorder. This bacteria is actually affecting our digestive system and causing so much of problem. Then alcohol intake and smoking. Alcohol intake and smoking, these two are these two could be the bad lifestyle ever a person can have. I'm not being judgmental, but yes, these two are the reason you can see the most of the problem we are facing in our life just because of these two habits. So then the next is cirrhosis, and then stress. Even stress can cause ulcer, because due to stress our nerves will be overstimulated, and then when nerve is overstimulated, it will just give a signal to the mechanism which actually controls the secretion of gastric acids, which is HCl. Okay, so gastric ulcer, we can see the risk factors are quite same: Helicobacter pylori, and gastritis if it is chronic or not being treated at first level. Then intake of alcohol, smoking, and use of NSAIDs, and stress. So here also stress is being seen, but use of NSAIDs means if the person is taking uh, painkillers or non-steroidal anti-inflammatory drugs at the, if they are taking, or you can say if they are misusing NSAIDs every then and now, if they are taking these medicines, then it can cause ulcer. Okay, so moving on to the clinical manifestation. Even the clinical manifestation I have put in the same way. So duodenal ulcer, it says here, you can see the symptoms like hypersecretion of stomach acid, HCl, which is uncommon. Okay, so here in duodenum region, the secretion of HCl doesn't secrete too much. Okay, so hypersecretion is actually very uncommon, which is seen in duodenal ulcer. In duodenal ulcer, when the ulcer is being formed, you can see too much of stomach acid, HCl, starts to secrete over there. Okay, and here patient have the chance of gaining weight. Then pain, because it's the skin is being perforated and skin is being damaged, so there will be pain. So pain occurs 2 to 3 hours after a meal. After the person has taken the food, after 2 3 hours only the person will get to have the pain. Why it happens, I will say, because duodenum is the part of small intestine which comes after the stomach. So once the food has reached the stomach, it will take time to move into the duodenum region. So that is the time period of moving that food from stomach to the duodenum, and then person starts to feel pain. And then often person will be awakened between 1 to 2 a.m. in the morning. So it says that due to pain, or maybe they will due to pain, they will wake up in the morning, because in morning our food is completely digested, so they will have a mild pain. And once they start eating food, they will take a lot of food, or then after taking food the pain will be actually subsided, but again after 2 3 hours they will start having pain. Reason is the same which I told you. Then vomiting, here the person will experience vomiting. Then hemorrhage is less likely than with the gastric ulcer. Here the hemorrhage chances is actually less than the gastric ulcer, but if it is present, then also you can see it as melena, which is blood in stools, are more common than hematemesis. Hematemesis is actually the blood present in the spit. When the person spits, you can see there is a blood presence. So this thing doesn't happen in duodenal ulcer. Instead, we can see melena, which is blood in stool. When the person is passing stool, they can see there a reddish color discoloration, or they can actually see the blood thing there. So that happens because the duodenum is the small intestine. From there the food actually starts to digest, and the feces starts to form from there. Okay, so if the problem is there, it's in the lower digestive system, so it will appear in the stool of the patient. And the gastric region, the stomach is actually situated in upper digestive system. So here the symptom will be appearing as hematemesis. Now it says more likely to perforate. Here it says in duodenal ulcer, because duodenum is a pipe like of thing. If you see that small intestine, it's like pipe. Okay, so it's small, it's curved. So there it's more chance of having perforation. Perforation, it means like erosion. So it will perforate or penetrate. So here the chances are more. Now gastric ulcer, the symptoms could be hyposecretion of stomach acid, which is normal. There could be normal HCl secretion, or there will be less secretion of the HCl acid. Then here weight loss is being seen in gastric ulcer because the person will be having vomiting, whatever they eat, it is coming out of the mouth, so nothing is going in. That's the reason person will start having this weight loss problem in gastric ulcer. Then here the pain occurs 1.5 hours after a meal, or rarely it occurs at night. And it says that here when person eats the food, immediately within 1 hour or after 1 hour they will start experiencing pain. The reason is that the food is going into from esophagus, it will go into the stomach. Once it reaches the stomach area, acid will start producing to digest and metabolize the food. In that process, that ulcer area will feel kind of irritation, first of all because of food, secondly because of HCl secretion. Then ingestion of food here does not help. Like in duodenal ulcer we have seen, the person will eat food and they will feel that the pain is relieved for some extent. And in gastric ulcer it doesn't happen the same way. But yeah, here it is seen that if person feels like to vomit, and if they go and vomit, the pain is bit released in this condition. So in duodenal ulcer, eating will be relieving the pain, and in gastric ulcer, vomiting might be relieving the pain. And it is seen that common hemorrhage more likely to occur. Here in gastric ulcer, hemorrhage or internal bleeding, there are more chances of this to occur in gastric ulcer. And here the person will not have melena problem. Here they will have problem in hematemesis, like when they are puking, maybe in their vomiters there will be blood presence, or maybe when they are spitting there will be blood presence. So these things are seen in gastric ulcer and duodenal ulcer. So I hope the clinical manifestation part is clear to you all. If there is any medical term uh, which is not being understood by you all, you can just ask me down in the comment section, I'll explain that, or you can just google it. So moving on to the pathophysiology, I have put a figure image over here to give you a better picture of understanding. So here you can see, let me take my pointer. So yeah, this is normal. This whole thing is normal. So normally our skin looks like this. First of all, we have this mucus area, and then we have this mucosa, which you can see like this, like a spiral. And then here we have our muscles, and down beneath we have our submucosa. So usually this is how our mucosal wall is made up of. So first we have mucus, and why we are having mucus? Mucus is a kind of defensive force. Okay, it's a defense mechanism we have against HCl acids, against any kind of infection and bacteria. So it says the damaging factors or damaging forces like gastric acidities and peptic enzymes. Yeah, I forgot to mention even pepsin. Pepsin is also a factor which can cause ulcer. When our stomach and when the mucosal wall and all the defense factors are not able to withstand this pepsin and acidity of gastric acid, then the peptic ulcer will form. So we have our defensive forces like surface mucus secretion here, keep on secreting over here in this region, and then also bicarbonate secretion into the mucus. So to dilute the hydrogen ion from HCl, we have HCO3, which is HCO3 minus, it's a bicarbonate. So we have bicarbonate secretion into the mucus to dilute the hypersecretion of HCl, to dilute the H plus ions. Then mucosal blood flow, then apical surface, membrane transport, epithelial regenerative capacity. If the epithelium is being diminished, or anything had happened, then there is a regenerative capacity to the epithelium. Now, elaboration of prostaglandins. So these are the defensive forces our body has it already. Now, in when this injury happens, in case of injury, this injury could be a Helicobacter pylori infection bacteria, this could be aspirin, or this could be any other medicine. which is painkiller and has been taken or misused by the patient over a long period of time. Then having cigarettes and alcohol, gastric hyperacidity, that is because of hypersecretion of HCl. Then duodenal gastric reflux, that is GERD, or maybe in case of gastritis. So these are the factors which we are calling as causes. So once these causative factors comes in contact with our normal skin, so what happens? So our defenses will be impaired. These defenses will get impaired when they are not able to withstand these risk factors. Then there will be impaired defenses, and then ischemia will occur. Ischemia is lack of blood in the muscles. So ischemia will occur, and then the person may get into shock. Shock is not like electric shock, but yeah, shock is decreased volume. There will be a decreased fluid volume, that is shock here. Then delaying in gastric emptying. The person may not feel like to pass stool usually on time, so the food is gonna remain back in the stomach and intestine for long period of time. And then there are some host factors. So these two things will occur. Once this injury happens, our body will not be able to withstand, and it will turn into these things: ischemia, shock, delayed gastric emptying, and host factors will happen. So once these things are happening, there will be increased chances of damage. So how the damage occurs? So we had this mucus over here, and after that we had a mucosa in spiral form, and after that our muscle, this is our muscle region, and down here we have submucosa. So you can see this bacteria, this infection, and alcohol, cigarette, and HCLs, all these things has started eating out the mucus and mucosa region. Even it will reach the muscles. These this were this You can see it is our defense, or this is the layer which is this is the layer, stomach layer, or stomach lining, or intestinal lining. And in ulcer cases, these lining will be completely necrotized. So once it reaches the muscles area, so you can think that how deep the wound has become, and then it will be necrotized till the muscle. Then you can see over here necrotic debris. So after dying, the tissue are remaining here. Tissue, even the dead tissues will remain here, and then again there will be gangrene formation, which is worst condition. So inflammation, all there will be inflammation, there is granulation tissue, there is non-specific acute inflammation, there is fibrosis, you can see. So all these things are happening inside your stomach or duodenum in case of ulcer. So this is peptic ulcer formation. Pathophysiology part is clear. Now moving on to the potential complications. So complication says in this peptic ulcer, there are chances of internal bleeding, there are chances of perforation, because anyway the problem will start from the mucus and mucosa, and then it start perforating down to the muscles and then inside some mucosa. So this is how it occurs. Then penetration is also the same thing, from upper layer to the inner side of layers. The mucosa and epithelium will get affected. That is the potential complication. Then pyloric obstruction. Once it happens in pylorus region, there will be gastric outlet obstruction, and the person will have constipation. Now, assessment and diagnostic findings. So first of all, we'll do a history collection, and secondly we'll perform physical examination and ask the patient about their pain, how the with what kind of pain they are having. Epigastric tenderness, we can see if there is any distension in the abdomen region. We can see that too via palpation, inspection, percussion, and auscultation. Then we'll start with the we can perform a barium study. So barium study, we have studied how the barium study happens. So the person will consume barium, and then we will have their x-ray, and we will see how the barium is passing throughout the digestive tract or gastrointestinal tract. Now endoscopy will happen to visualize the exact picture, how it is seen inside and what all the things are happening inside. We can visualize it on our system screen. via endoscopy. Now, biopsy of the gastric mucosa and of any suspicious lesions can be obtained. So it says that in this at this level we have to take a tissue part for biopsy purpose, and we have to study that tissue to find out if there is any suspicious or any miscellaneous kind of lesions are present, um, which can form into a cancer cell later on. So biopsy is also required. Then stools, we have to send patient stool sample for occult blood examination. In case of duodenal ulcer, usually we send stool sample for the test. Then serologic test we have to perform to count the or to see the antibodies of Helicobacter pylori antigen, because if it is because of Helicobacter pylori bacteria infection, then we have to perform this blood test to find out the antibodies presence in the body or in the blood. So this is about diagnostic findings and managements. In management, because infection is there, so we will try to treat it with antibiotics. Then it could be because of HCl production, then that this could be treated via by giving antacids to the patient. Then histamine H2 receptors antagonists or proton pump inhibitors are suggested in this condition. Ask the person to take adequate rest and give them some sedative and tranquilizer to ease their pain, so they can have a little bit of less pain, because it's a very painful condition after eating, with eating, or before eating. It's all the three time person will be in pain, so give sedatives and tranquilizer to ease their pain and provide them some comfort. And we can give them sandostatin medication. It is to be given to suppress their gastrin levels. Here we are suppressing the enzyme level in the stomach. Then frequent gastric aspiration is performed to allow monitoring of gastric secretion of pH. So here we can just perform gastric aspiration the same way how we aspirate the gastric content in case of NG tube. After putting a NG tube, we take 10 ml or 20 ml of syringe, then we just aspirate the content, and that content has to go for laboratory testing to see what is the pH of that gastric content. Okay. Now, the surgical management. Surgery is usually recommended for patients with intractable ulcers. So, those that have failed or failed to heal, or maybe after 12 and 16 weeks of medical treatment, there was nothing uh, successful in the treatment scene for the patient. In those patients we can perform surgery. And if there is any life threatening situation, like the internal bleeding is too much and we couldn't find out the cause of internal bleeding, then immediately take the patient to the OT or operation theater. Then in case of perforation, if the perforation is too much, because you saw the layers of skin, so if the perforation has reached beyond muscles, then we have to take the patient to the for the surgery. Then if there is any obstruction or maybe form of fissure or fistula, in that case also surgery is the only option. Then, and for those who are not responding to medication, obviously if the person is not responding to the medications, we can't just wait for something worse to happen. We have to do something to save our patient's life, so we'll perform surgery in those kind of patients. So here we are doing vagotomy with or without pyloroplasty. What is vagotomy? Vagotomy, here you can see word tomy, which I told you late before also. Tomy is in making incision or opening. So here we are gonna do incision, or we will just remove our vagal nerve. Vagal nerve is one of the nerve we have in our body which is extended throughout the body, and this nerve is actually controlling the mechanism of gastric secretion, which is HCl acid. So there might be a hypersecretion of HCl, there might be a hyposecretion of HCl. That is also happening because of vagal nerve. So we'll just remove that vagal nerve from gastric region, or we can perform it with or without pyloroplasty. So pyloroplasty, plasty means reconstruction. So reconstruction of pylorus, which is pylorus region. So we are reconstructing the pylorus region if the ulcer is formed in pylorus. Then performing Billroth first and Billroth second procedure. So these two are the procedures we need to perform. So I'll just give you a brief about it. So Billroth first procedure, it is the removal of the lower portion of the antrum of the stomach. If you know fundus body and antrum, how the stomach part is divided, so here we are gonna remove the lower portion of antrum of the stomach, which contains the cell and also secrete gastrins. So it, as well as a small portion of the duodenum and pylorus. So these three things we have to remove or cut out. So the remaining segment is again anastomosed and fused to the duodenum. In Billroth first procedure, we are removing and anastomosing these to the duodenum. In Billroth second procedure, the same incision and same removal of lower portion of antrum of stomach will happen, but here we are gonna fused or anastomosed it to the jejunum. So that happens in Billroth 2 procedure. Now this is all about the surgical management. Then moving on to the nursing management. Nursing management will be, we are gonna um, give our more, yeah, here we are gonna give more stress on relieving the pain, because pain is gonna be severe for the patient. So relieving pain is our ultimate goal. Then trying to reduce the stress of the patient and asking the patient to take rest as much as possible. Then cessation of smoking, asking the patient to stop smoking, which will not happen all of a sudden, of course. So you have to give proper health education regarding smoking cessation, and make some dietary modification if there is, because the person will go undergo the surgery and there is ulcer, so there are a lot of food modification need to be performed, like cutting out the spicy foods, cutting out taking hot beverages or hot food, and there are some other irritant kind of food which need to be avoided, and also some food ingredients which has to be avoided for these kind of patients. So refer the patient to the dietitian, get them a proper diet plan and give proper health education, and yeah, teach the family member how to take care of the patient. Then moving on to nursing diagnosis. Nursing diagnosis is acute pain related to the effect of gastric acid secretion on damaged tissue. So here the pain will happen because of the HCl acid which is damaging the tissue. So here we'll write the same way. Then anxiety related to coping with an acute disease. So this is something which will make a person very anxious, very worried. So anxiety will come. Then imbalanced nutrition related to changes in diet or related to whatever the reason you are writing, you can write it here in related to the nursing diagnosis. Then deficient knowledge about prevention of symptoms, management of the condition. So this is about nursing diagnosis, and the topic is over. I'll just give you again a look. So we started with definition. Moving on to the incidence, risk factors, signs and symptoms, pathophysiology, potential complications, assessment and diagnostic findings, management, medical management, surgical management, nursing management, along with the nursing diagnosis. So here we have finished our peptic ulcer topic, which is very important. I'm just reminding you all, do not forget to read this, and the slides which I am providing you, it's for you to prepare well, so you don't have to look for the content here and there. It's based on 10 marks I prepared this slide, so you can have it and just write this blindly in your exam. Learn the nursing diagnosis, try writing specific and particular nursing diagnosis which is applicable on that disease condition. Okay, So this is all. Thank you for watching. See you in the next episode. And till now, so by then, study well and bye bye.